When someone is diagnosed with a brain tumor, their world can shift overnight, bringing challenges that reach far beyond the medical diagnosis. A tumor is first and foremost and most obviously a health challenge. Like any serious illness, however, it also taxes people mentally and psychologically. Patients and their families have to navigate a complex medical system, take in new and challenging information, and make large, potentially life-changing decisions. Because of this stressful environment, Pacific Neuroscience Institute's Dr. Shanthi Gowrinathan, a psychiatrist who specializes in treating people with cancer, is part of a team that helps people cope with the mental aspects of their illness. In today's episode, Dr. Gowrinathan explains how she helps patients and their families maintain their sense of self in the face of tremendous challenges. Hi, I'm Dan Faust. I'm the host of the Think Neuro podcast here at the Pacific Neuroscience Institute. And it's my pleasure today to be here with Dr. Shanthi Gowrinathan. And Dr. Gowrinathan, would you please introduce yourself? Tell me what type of a doctor you are and what you do here at PNI?
I'm Shanthi Gowrinathan, and I am a cancer psychiatrist, otherwise known as a psycho-oncologist. I'm a psychiatrist who went to medical school, did residency in psychiatry, and then chose to specialize in medically complicated patients. So that makes me particularly well suited to working with cancer patients.
Great. Thank you very much. And I know when we were speaking earlier, you had asked me about what I was interested in knowing about cancer patients and brain tumors in particular. And I wanted to share the story of my friend Marilyn Enos, who several years ago was diagnosed with a glioblastoma. And what was interesting to me about Marilyn's case was that she had gotten some new technology in her home that she felt contributed to getting this disease, that there had been no history of any kind of cancers in her family. And she plugged into a network of other people who were looking at what in our environment might be causing these problems. And I have always wanted to, as a journalist, wanted to honor Marilyn's memory by trying to get to the bottom of that story or find out what is the research telling us about that. But I have also always been fascinated by the phenomenon or the notion that people look for an explanation for sometimes things that may not have an explanation or may not be able to be explained. And I think that's something that you probably deal with all the time, and I'd love to hear about your perspective on that.
Yeah. First of all, I'm sorry about Marilyn.
Thank you.
I think if you do find the answer to why brain tumors happen, PNI should be the first to know, because we would love to be able to not have patients to treat anymore. I think that would be all of our goal. In terms of searching for that answer, I think that is a really common sort of processing question that people ask. There's a lot of phases. People like to quote the sort of steps of denial and anger and all this when talking about how people handle the news that you have a life-threatening illness in the same way that people do grief. But I think one of the things that's different is that, unlike with grief, in this case, you kind of got your mortality shoved into your face. Someone just walked into a room, and with brain tumors, it's very common that it happens in a way where you really weren't expecting to get this news. You maybe had a headache, you thought you needed migraine medicine, or some people, they don't really even have that many symptoms until very suddenly, right? So you get this news, someone walks in the room and tells you this thing that makes almost no sense and doesn't fit into your life and you didn't ask for. And so there's a lot of grappling with not only making sense of that, which is where the why did it happen, what is the root cause here, the search for the etiology, where that comes in, but there's also grappling with our mortality being right here, right next to us, hanging out. Um, Human beings are really good at living in a world that is constantly filled with danger. If you're a parent, you know this. You look at your little one who thinks that they can crawl or thinks that they can walk or thinks that they can drive a car, and you're terrified by the number of things that could go wrong in a day, right? Like, I mean, just there's so much that you can think of. Um, so we're really good at, in order to survive in the world where we are vulnerable, but we keep going, we're really good at kind of putting the blinders on and staying well away from our mortality if we can help it. And something like this, it it makes it almost impossible to ignore the fact that you are mortal and that there is a lifespan. And in the case of brain tumors, there's a question of how long that lifespan is going to be. Um, so I think people naturally want to regain control. We want a little bit of blinder back. We want to push mortality a little bit away. And so I think it's a twofold thing. One is we're trying to make sense of something that we did not ask for that now is going to change the trajectory of how we live. And the second is truly just trying to reestablish control over something that feels very outside of our control and scary. You know, human beings are not meant to think about their mortality all the time. So when you're going for doctor's appointments and you have to do treatment and there's constant reminders and things about yourself are changing, these are some of the things that people do to cope. And asking why it happened is one of them.
And and in your job, quite often that's the point where you're meeting the people. You're coming in probably not too long after they've met with the uh, the brain surgeon, the neurosurgeon, or the doctor who is giving them that news, and then it's your job to help them process that.
I'm always shocked by how strong people are and how much people can take. Honestly, a lot of these patients actually I don't meet them right away. They they listen to the doctors, they might get some second opinions, they start treatment. The brain really quickly assembles a game plan when it needs to, but it pushes the emotions aside for later. So when I get to meet with people or when the need kind of becomes obvious that they need to see the psychiatrist, it's usually either because treatment has induced something. A lot of the treatments we use in brain tumors and cancer, including things like steroids, will induce symptoms that make people feel like they need help. Lack of sleep, severe lack of sleep. Um, anxiety, depression, a feeling of restlessness, not being able to relax. These are all things that then require me to come in and try and counteract that. But I think the other thing is a phenomenon that I just, when I'm talking to patients, I'm like, look, the dust settled. That's why you were able to power through treatment. You were able to power through everything. And now, when people are saying you're a little bit better, this is when all of a sudden you need to see the psychiatrist. All of a sudden you're not doing so well emotionally, right? Because it hits us when we're busy doing it. It's easy to keep going and keep our head down. But then when it gets a little quieter, when it gets a little more still, is when it hits us. So a lot of times that's when I come into the picture, but I can come in at any point in time. Um, and
Yeah.
it's a privilege every time, no matter where it is.
Why do you say it's a privilege?
Why is it a privilege?
Yeah.
Because I think that there are moments in every person's life where you're burned down to your essence, not because you wanted to be, but because either suffering or grief or loss has made it so. And to be able to walk with someone during that time, to be able to um, sort of see who they really are, what the essence is, and then help them build themselves back up from that. I mean, I don't know how that could not be a privilege. It's a privilege. It's
Yeah.
the most beautiful part of people that I get to see.
Yeah. Yeah. The and you've also talked about people fearing the loss of who they are. I mean, it's interesting that you're talking about that they're getting to down to the essence because it's also something they want to hold on to, or all the different things that they think this is what makes me who I am.
Yeah, and I think that there will be losses, but it's heartening to know that who we are is pretty strong. It's pretty firm, kind of like that tree behind you. It People are able to see that over time. I think when you treat psychiatric symptoms or when you talk people through the moments where they're lost, I think on the other end of that, they find out that they're pretty well anchored and they're able to keep going. So yeah, so a lot of it is um, reminding people of what's there and which parts are real and which parts are just symptoms and they're going to go away, which parts are going to get better and ease, all of that.
Do you have a process for that?
It's different for every person, but yeah, yeah, we do. I work with a larger team. We're cancer support services at Providence St. John's and PNI, and so we have social workers who do distress screening and really focus in on which part of someone's life is causing distress. If those parts happen to be psychiatric, then the patient comes my way. And then when a patient is doing better and they're really on that part of the journey where we're trying to get back to life, we have a survivorship program and a survivorship nurse practitioner who works with them then as well. So um, we try to have services that touch every possible point in a patient's journey. And then after that, it really is meeting the individual and understanding where that individual um, wants to be seen and wants to be heard while going through this and helping amplify their voice so that they can be seen and heard, advocating with doctors, and then doing the real nitty gritty of medical psychiatry, which is understanding where the tumor is, what the impact on the brain and the mind is, and then very importantly, what that is doing within the context of the body that is undergoing treatment. And then using all of that to understand what part is really psychiatric and what part is medical and can be treated. And then for me, the fun is kind of the diagnostic finesse and seeing how many symptoms I can treat with how little medication. It works because we get people who really turn around. I mean, just profound changes in both outlook and their outcomes regarding their cancer treatment. But when I go to a party and say what I do for a living, people always say to me, "Oh, that must be so depressing." And it's so funny when people say that because it is the exact opposite. Like, my job is to help people get back to themselves. And you cannot watch people go through cancer or brain tumor treatment and watch how they persist and how they show up and how they suffer and keep going, and then suffer less and then do better, um, without being uplifted. So it's honestly amazing. It's amazing to watch people.
Stories of how people come through these dark moments and find the strength to carry on can be so inspirational. I asked Dr. Gowrinathan if she could give us an example of a patient's story in this regard, how someone had temporarily lost that sense of self and then, with Dr. Gowrinathan's help, rediscovered their core personality. Dr. Gowrinathan shared one such story, taking care not to reveal any identifying details.
There are patients who have brain tumors and face tumors, and unfortunately, sometimes in the process of treating them, we're left with very visible deficits. So, deficits of the face, or deficits our movement, deficits in how we speak. And so these are deficits that are very socially visible, right? So, one of the difficulties is number one, you're going through something that is very hard and we really don't want advice from everyone in the grocery store and everyone, when we're standing and waiting for an Uber. And when you are visibly different, people not only have questions and comments, but you're a little bit hyper aware of your cancer because there's a constant reminder, right? Like you can look in the mirror and there's a reminder. When you try and speak, there's a reminder. When you try and swallow, there's a reminder. So our head and neck and brain tumor patients with visible changes are a population that can be um, a little bit more emotionally fragile and a little bit more desperate because they start to pull away from the world very quickly. And the one danger in psychiatry is when you socially withdraw and you socially isolate, it's really easy for our brain, our mind, our silly thoughts to lie to us and tell us things like, "It's not worth it. You don't need to be here. Like, it would be better for everyone if you were gone." So this population, we're very careful, right? We will keep a close eye. We surround them with resources. And so there was one patient in particular recently, when she came to me, I was scared because I was being given a patient who had visible changes, had to wear a device in her mouth to be able to swallow because there's a bit of a hole, and that device was upsetting to her, and she had to clean it every day. She'd take it out and clean it every day, and that was upsetting. And then, she had pain. She had pain and nerve weirdness. I call it weirdness because everyone feels it differently, and sometimes it helps to use silly words for these very serious things, but it was constant, and it was all in here, and so you can't walk away from this reality, right? Like, this is a reality that exists. And she was very angry when she came to me and she was like, "Look, unless you're going to tell me that my reality is different, I don't want to do this. Like, I don't want to do it anymore. I want to be done." And I asked her to give me 2 weeks. I said, "Give me 2 weeks. We'll talk a lot. Um, and I need to be able to start medication and you need to be okay with trying something." And we did. We started medication. In this case, it was something that acts as a mood stabilizer, and she stabilized. So, I saw her a couple weeks later. She was less teary. She was still upset by these things, but she was less teary. But that time, she had reconstituted enough that we could really talk about the reality. You have to be really careful about poking at things when people are in crisis. But she was just well enough that I could talk about the reality. And even this obturator thing that was in the mouth, it wasn't that it caused pain or discomfort, it was that taking it out, cleaning it, and putting it back in was a constant reminder. So I actually went to her, dentist doctor person and asked them if she could do it less as long as she kept her mouth clean. And that was just enough of a compromise to give her breathing room. She didn't have to clean it as often, and she could breathe, and she felt a little better. And that's something that I do commonly with patients is I'll call the doctor and be like, "Look, this thing, this expander we put in the breast, this thing that we're doing to try and make this person better has become the focus of the brain's I can't. So, can you help me to dismantle that I can't a little bit? Can you give me some space here?" And the doctors are really good about calling me back and being like, "Yeah, here's what we could do. Here's what's not possible." Right. And I always respect their judgment because this is their world. But we gave breathing room, we allowed medication to work. And I saw her 2 days ago, and it had been about a month and a half. And she said something really lovely to me, which I'm going to change because I don't want her to feel exposed. But basically, to something to the point of, "I've started living again, and I'm doing good living." And um, I get goosebumps just saying that because um, there are days when it's so hard and you're not really sure if what you're doing is making a difference. And then there are days where someone who thought it wasn't worth living comes back to you and is like, "I joined a swim team," or "I joined a book club," or "I joined a support group." And yeah, that thing that I was focused on that I said I can't stand is still there. But I think I'm okay with, I don't know, I haven't been thinking about it much. And it's just I'm so proud of that brain because that brain let go of the perseveration. It let and all the brain wants is control over this uncontrollable situation. So the fact that medication can allow that brain to let go of that control and stop torturing the person that, lives with that brain is it's wonderful, and it's also what we want. We don't want to save someone's life in order for them to feel that living is untenable, right? We would like to save someone's life so that they can live and thrive. And so, I think there's something in that story, and it's not just one patient, it's actually many patients where this is the case, based on taste changes, based on being able to eat a hamburger again, based on being able to get through a day without feeling pain here. And the medications change certainly based on symptoms. But I think the point is we think that because we survived cancer, we kind of have to just put up with whatever comes with surviving cancer, and we kind of just have to like be grateful and suffer. And that in this day and age, that is not true. We have plenty of science. And if you have a good psycho-oncologist, if you have a good pain management doctor or palliative care doctor, if you have good thinking people, you can break down the parts that seem undoable for you. And with behavioral interventions, like not having to clean the thing anymore all the time. And I do other things like yelling at people and being like, okay, you have to get out for a 5-minute walk. If you do nothing else with your life, get out for a 5-minute walk, notice things, take a picture of something and send it to me, right? I call them noticing walks, but just regrounding ourselves in the world. There's all these behavioral interventions we can do. And then there's the medication, which is necessary because the brain can only take so much. So the medication is to reconstitute things for the brain so that it can then allow the spirit to rise. And then the human being does the rest of it. I don't have anything to do with the rest of it.
Wow. And I imagine, especially in a brain tumor patient, because both the disease is affecting the brain itself, and then, as you said, some of the medication, whether it's radiation or chemotherapy or even a surgical intervention, will also affect. It's going right into the area that's also supposed to be processing all of this.
Yeah.
So it's a double whammy in some sense.
It's a double whammy and it's scary because it's what we associate with who we are, right? Our personality, how we laugh, how we see the world, what we think, how quickly we think, all these things, our cognition, what we're good at math, we're good at science, we're good at reading, whatever, art. So part of the process is accepting and being aware that there will be loss. But part of it is either getting people back to what they want to be doing or finding new things if we can't do those things.
The and you said, I mean, the medication can be so helpful, but you try to do as little as possible.
Yeah, I'm a notorious underdoser. So what I found is even if a patient had a history of anxiety or depression before their cancer, I found that cancer and cancer treatment and whatever it is that we're going through makes the brain a little bit more exquisitely sensitive. And so I tend to use really small doses. I tend to be really respectful of people not wanting to be on these meds. So I'll tell them I'm putting you on a baby dose so that on a Tuesday, when you decide I don't want to take Dr. G's meds anymore, you can decide that. I can get you off. You won't have withdrawal. Um, I have no vested interest in people taking medication. I only see medication as sort of the stepping stools that I use to kind of get people places faster, right? Like it's just a little bit of a shortcut and a zoom towards where we need to go.
Mhm.
Most of my patients eventually come off medication, right? Most of them don't stay on medication.
Whether we consciously think about it or not, we all tell ourselves stories about our own lives, who we are, and why we are the way we are. Those narratives often get disrupted when there's a diagnosis of a brain tumor. Few diagnoses are as life-altering, messing with the very part of us, our brain, that is needed to process this new reality. A cancer psychiatrist like Dr. Gowrinathan can help people understand the narrative that they've had, how the diagnosis fits into their life story, and whether they can change their perspective as they go through treatment.
A long time ago when I was little, I was going to be a writer. So I was going to tell stories. Um, and this is fun because um, when you go and talk to people when they're struggling, you're still telling a story. You're just telling a story about how you're broken, of how you're defeated, how it's not fair and you're angry, but you're powerless. They're stories that are valid and probably based in evidence, but unhelpful to us. So I think part of it is really validating where someone is in their journey. If they are angry, we're going to be angry. If they are sad, we're going to be sad. But then, especially if we are able to use medication to ease for them anxiety, depression, anything that is really skewing our perspective and making the brain think mean thoughts, um, when those lighten, then the real beautiful work is just helping people understand where this thing that happened that upturned their life fits into the larger picture of their life, and how can we write it so that this thing that happened that we didn't want becomes part of our strength or our growth or how we got back to ourselves, like part of that story. And so, and I think that at the end of the day, even if we do not succeed and someone succumbs to their cancer, or they are unable to um they're unable to keep going, they want to stop, even if that's their choice, or even if it's not their choice, but that's what happens. I think there's a great deal to be said for having hope every step of the way, even when we're dying. When we're dying, we might change the story. We might hope for a peaceful death, or we might hope for um, resolution with family members. We might hope. One of my patients was like, "Gee, I just want to go in the ocean with my brother and sister and hold hands and look at the sunset. That's what I want." And we did make that happen. We did make that happen. We have something called EOLA in California, which is End of Life Act, and so it allows us to do death with dignity for people whose prognosis is now very poor. And that's what she did. She got her sister and brother out here from the East Coast, and they stood and looked at the sunset while standing in the water, and I talked to her that night, and she passed the next day, and she had a tremendous amount of peace. Very peaceful person that last day. She was not a peaceful person when she was going through it, and we worked really hard on that, but we were able to work to the point where she got to write her story the way she wanted to, and that's what we all want. We just when the uncontrollable happens, we're like, "Hold on a second, my story, I wanna write it." So just empowering people to be able to write part of their story, even if they weren't able to write that particular bit, um, it's tremendous. I mean, what it does for people is allow them to be, um, hopeful, right? Because they 'Cause they're gonna write it. So
Right.
that's hope.
And a big part of when people are going through this is the people around them as well, and how they respond, or the illness is making them irritable or snappy, or
Yeah,
to
there's a lot of, education around family. I think one of the things that's done really well at St. John's and also at PNI is that the caregivers spend a lot of time talking to family. And there's two different kinds of caregivers. There's medical caregivers, who are the people giving the medical care, and then there's the people taking care of the patient, which we also tend to call them caregivers. Family members, friends, whoever is coming, helping them to understand. I think my favorite thing is husbands and wives when the husband has prostate cancer or the wife has breast cancer. And we give a whole bunch of hormone treatments that block hormones. So we essentially put both men and women in a kind of fierce version of menopause,
Mhm.
and it makes you a little cranky pants, I'm not gonna lie. Um, and so, one of my favorite things is just being able to lower that for the spouse and help them understand where their spouse ends and where side effects to medication and hormonal changes begins, and
Mhm.
then helping the patient understand what we can do to treat some of that so that we don't wanna hurt the people around us who are trying to take care of us, and we don't like the look on their face when we are snapping and we don't know why. So I think on both ends, like, education really helps with family members and friends. I think that's so important that we don't assume that people know what the treatments are doing to that patient or what it feels like to be going through that treatment. And then for the patient themselves, helping them manage those symptoms, treat those symptoms so that they can have moments of really beautiful interaction with their family instead of cancer and a very stressful family life, because we know that outcomes are worse when it's that way. And we know outcomes are better if you lighten that for people.
Mm.
Yeah. So a lot of education, a lot of support around the caregivers. And that's something that we have to work on as a society, because we're going to have more people caregiving, and we're going to have a very large older population. And um, in insurance, in the things that pay for things or pay bills or pay hospitals, there's not a lot of coverage for helping the people who care, right? Like, we get to help the patient and that gets covered and that's paid for. The rest of it is not. So at St. John's, we're very lucky. PNI and St. John's are very good at philanthropic funding for our cancer and brain tumor patients. They make that a priority. So we're able to offer services also for caregivers. But if you're at an institution that doesn't have that, as a caregiver, you're not going to get that education. You're not going to get that time from the doctors and the nurses and the staff. So it's it's something that we need to do a better job at, and it's very important to the patient's outcome.
And they have a horrible diagnosis and they don't want to hear, oh, it's not so bad, or other people have had this, or I don't know, any number of ways we always try to sugarcoat or put a positive spin on things. And sometimes maybe people just want to acknowledge this is terrible.
Yes. We we try not to candy coat, but I also think everybody has their own way of dealing with things. Like, some people want all the information, some people don't want any information. Some people kind of almost want to keep it secret. It's like their secret identity is being a cancer patient and they go back to their real life. Some people want to embrace it and wear it on bracelets and t-shirts, and so everyone has a different way, and I don't know that there's a right way, but that's what I mean when I say we have to meet people where they are. If I make a mistake and I say to someone something that they don't want to hear, I hope that I've also, somewhere in our interactions, encouraged them to advocate for themselves. So when they say to me like, "Oh, I don't want to hear about that. It makes me nervous," then I correct myself and I tell them, "I'm so glad that you're advocating for yourself." Right? Like, "I'm so glad you said that. How would I know that what I said upset you? And I'm sorry." So I think expecting family members and friends and people in grocery stores to know what we want to hear is hard. Brain tumors in particular, because people don't know much about brain tumors. They don't understand. A lot of times my patients will complain of things like, I have a meningioma, and because I said the word benign, now everyone thinks I'm fine. And the reason why I see the meningiomas, the benign brain tumors, is because they go through the same treatments as cancer patients, and they
Mm.
go through the same side effects and loss and changes. And so, yes, it's benign, and we're very happy about that. But that doesn't mean that it isn't life changing, life altering, and hard, right? So, I think
Because
one
it
of the
has to
things
come
is
out.
just allowing people the space to advocate for how they want to deal with this and how they want to interact about this. Not necessarily deciding how they should, but just kind of helping them to advocate.
Dr. Gowrinathan is not the only doctor considering these issues as she deals with patients. The neurosurgeons at PNI also navigate that delicate balance. They need to understand each patient's desire for certain types of information. The neurosurgeons rely on people like Dr. Gowrinathan to help them gain that insight into what each patient needs.
Working here, I mean, the neurosurgeons are so nice. They give me their cell phone. I call them and bother them all the time. I've worked at institutions where people are like, "Why are you calling us? You're the psychiatrist." And to me, it's so obvious why I'm calling. I'm calling because in order to get good care, we have to treat the whole person, and the mind is important and it's in there. So I got to call you. But I think it I think we all learn from each other. I learn how to be a little bit more detail oriented, because surgeons tend to be detail oriented, and I admire that about them, and I imitate as much as possible. And I think, yes, they learn maybe more of the words. I especially here at PNI, Dr. Kelly or Dr. Barkadarian will see a patient, and I'll walk in and see the patient in real time with them. And I'm learning from them and how they present about the brain tumor. And I hope that they are learning from me about how we accept whatever's coming from the patient, which, when we're getting unfun medical information, we're not always our best self, and that's okay. Um, so just holding space for that. We all collaborate and we learn from each other. And as far as I'm concerned, my experience since working here has been these are really lovely people who care about their patients. I've never had an experience that was less than that.
You're also in that liaison mode where you can have them explain something to you.
It's so nice. I've actually, sometimes they've let me come into the OR. And especially when I first got here, because they do a very specific kind of surgery here, keyhole surgery, that isn't done a lot of places. And so I had no past experience with this. So I asked and I got to go into the OR with them and watch them do a couple of surgeries, Dr. Griffiths, Dr. Kelly, Dr. Barkadarian. And let me tell you, it is, I mean, just goosebumps and amazing and like science and art put together. It's beautiful. And the way they do it is art. And then, yes, I can take that information and go and tell a patient this surgery that you're so scared about. Listen, I've watched them do it. I've watched how carefully they go in there. I watch how considerate they are of whatever they touch and what that's gonna mean for you living your life later, right? And yes, being able to tell someone that surmounts a great deal of anxiety. Like, being able to give them a visual of someone behaving like an artist in a surgical space really helps to bring down the anxiety, really helps them to have faith in the hands that are helping them.
Is there something you want people to know when they, once they've been launched on this journey that they didn't ask to go on?
I'm sorry you have to go on the journey that you didn't wanna go on. I'm really sorry, but I will tell you, there is not a minute of that journey that you have to do alone. And I'm not just talking about here at PNI and St. John's. If if you're here, we're very lucky we have all the services and you just have to ask and we will find for you. Um, but at most of the major hospitals, it is true that we recognize now that outcomes are affected by our mind, by our well-being, by our ability to treat psychiatric illness. These are all things that have been well documented as affecting outcomes and making people better if we address them. So I would just ask that people don't assume that something can't be changed, because almost all of it can be improved a little bit. There's very few things that can't be improved just a little bit. And even sometimes that's even enough. And then also, just remember to ask because you really, really, really don't have to do it alone. The surgeon sees you once in a while and they're amazing. But in the interim, when you're trying to go about life and you're having difficulty, come tell the surgeon, tell the office, tell the people who work there, and they will come find us and we will come find you. And that probably applies at most of the major institutions that treat cancer. Don't do it by yourself when there's all this here that can help you. That would be the only thing I would ask. Don't do it alone if you can ask a question and get help.
Yeah, I think that's probably true for most of life that we often think we have to do something alone, and yet there is a team. We're part of a team. We're not the only person that the spotlight is shining on.
There's this like really lovely image of the redwoods and then the ground under the redwoods and then the like vast array of like fungi and mycelia and like little creatures. Like there's a whole connection between everything that we don't think about. And I think we think that maybe that exists for nature, but not for us. But human beings are all connected and we are happiest when connected. So just reach out and someone will connect and you will feel better. That's it. That's all I want as a takeaway.
Well, thank you. I'm going to take that away. I appreciate it. And thank you so much for your time and for all that you do.
Thank you. It was nice to talk to you.
In this episode, Dr. Gowrinathan gave us a window into what it means to care for the whole person and not just their condition. When a patient receives a diagnosis, they aren't just fighting for their health, they're fighting to hold on to everything that they are. Through Dr. Gowrinathan's work, she shows us that even in the darkest moments, there is room to find hope, agency, and peace. Thank you for joining us today on the Think Neuro podcast. We'll see you next time.